Good morning, everyone, especially for those here in Asia Pacific and joining us online. Good day to everyone around the globe who is joining us here in APCOM's Community Summit RRRAP Conference. This is the first day of the RRRAP Conference, and we are starting the day with two concurrent sessions. Welcome to the session on undetectables equals to untransmittable. There's no time for excuses. We have to be implementing the key messaging of undetectable is equals to untransmittable here in Asia and the Pacific. The U equals U is a landmark research finding about people living with HIV with undetectable viral load cannot pass on the virus through sexual transmission. And the research was based on HPTN, Partners, and Partners 2 studies. The U equals U, the Partners 2 study is a real-life study, and we have the honor to play the pre-recorded presentation of Dr. Alison Roger, one of the principal investigators of the Partners 2 study. So with the support of EPIC project, APCOM has been implementing several webinars on U equals U. And we have started the U equals U webinar 2 months ago about understanding the science of U equals U. So for today, we are starting with the science of U equals U this morning, and then we're going to proceed with the key messaging of U equals U, sharing from or learning from the experiences of the community advocacies from other countries, and then how are we going to use the online platform to kind of generate demand using the key messaging of U equals U and generate demand for antiretroviral therapy. This session is being supported by the International AIDS Society and International AIDS Society Educational Fund and the Prevention Access Campaign, and with coordination with the IHRI, which is based here in Bangkok. So what we're going to see next is a pre-recorded presentation of Dr. Alison Roger, who is one of the principal investigators of Partners 2 study. So this video has been played already during one of our webinars, but this video is very packed with information and with the science and with the evidence of undetectable is equals to untransmittable. And it is just very fit to play again this video of Dr. Alison explaining the science of U equals U in this conference. So without further ado, let's all listen to Dr. Alison Roger, one of the Partners 2 study principal investigators, to explain the science of U equals U.
Scientific. So if we think about the state of the evidence, well, the science is now very, very clear. The data is indisputable, and the virus simply can't be passed on if you're on suppressive antiviral therapy. So although we've known about the impact of antiviral therapy on HIV transmission for a long time, saying that it stops it...
This presentation or this video was recorded 2 months ago, and it's titled The Scientific Evidence Supporting U equals U. And Prof. Alison Roger is from the University College London, and we're about to listen to her now.
3, we're on.
Great. So thank you very much for asking me to talk today about the scientific evidence supporting U equals U. So if we think about the state of the evidence, well, the science is now very, very clear. The data is indisputable, and the virus simply can't be passed on if you're on suppressive antiviral therapy. So although we've known about the impact of antiviral therapy on HIV transmission for a long time, saying that it stops it completely is really new and important. So over the next 20 minutes or so, I'm going to talk you through the scientific evidence underpinning U equals U, And I think it's really important to understand just how robust this evidence is underpinning the U equals U campaign, which I really think is one of the most important campaigns in the history of HIV. So I know that some of the evidence will be familiar to many of you, some of it may not be, but I think it's important that we really understand how robust this evidence is so that we've got complete confidence and can go out and spread the message around U equals U. Next slide. So the first thing I usually do when I give these talks is to remind people who are surprised about U equals U is that HIV transmission, even without a condom and without using antiviral therapy, is generally an uncommon event. So if you look at the type of sex we'd associate most with risk of transmission of HIV, that's receptive anal sex, even without a condom and even without using antiviral therapy, the risk is about 138 per 10,000 condomless sex acts. So all you're doing with antiviral therapy is taking it from the right-hand side of the figure and pushing it right the way down to the left towards no risk. And that's really what the antiviral therapy is doing. Next slide. So we've really had evidence now for about 20 years. So this was one of the first studies, the RRRAP study. This was in 415 serodifferent heterosexual couples in Uganda. So there was no antiviral therapy being used. But what they saw was this really clear gradient between the risk of transmission to the negative partner and the HIV viral load of the positive partner. So a very strong association both for male to female and female to male transmission. The higher the viral load of the positive partner, the higher the risk of transmission. And in the 51 couples where the HIV positive partner had a viral load less than 1,500 copies, there were 0 transmissions. Next slide. Next slide. So there were other cohort studies followed this RRRAP cohort. And in 2009, the Swiss group and Suzaia Ataya and Matthias Eggar, they basically did a meta-analysis of 11 cohort studies. So they combined all the data in about 5,000 heterosexual serodifferent couples. And they published this forest plot of summary HIV transmission rates per 100 person years, according to the use of antiviral therapy and the plasma viral load. So what you can see is this 92% reduction in transmission for people who were on antiviral therapy from 5.64 to 0.46 per 100 person years of follow-up. And they calculated this was compatible with 1 transmission per 7,900 sex acts, but this was a lot lower than the Swiss statement. Next slide. And the next slide, sorry. The next slide. And the WHO view at this time was that there was insufficient evidence to formulate guidance on the role of antiviral therapy in HIV prevention, either at the level of the individual or at the population level. Next slide, thanks. So luckily, shortly following that, we got the absolute gold level of evidence in the form of a randomized control trial. And this really was a landmark study in the field. The HPTN 052 study, which recruited 1,763 serodifferent couples, so again, 1 positive and 1 negative. The majority of the couples were again heterosexual couples. And they randomized the positive partner to either go on immediate antiviral therapy or to go on delayed antiviral therapy, and that meant waiting until the CD4 count dropped below a predefined threshold. And their primary outcome was a phylogenetically linked transmission event, and using phylogenetics was important. It was really the first time this had been done, because we know in all the transmission studies, if a negative person becomes positive, it doesn't necessarily mean it's come from their positive partner in the study. So this was incredibly important to show just how robust antiviral therapy was. Next slide. So the study was due to continue till 2015, but in 2011, the Data Safety Monitoring Board recommended that the results of the trial were announced immediately and that everyone in the delayed ART arm was offered immediate antiviral therapy. And this was because the degree of protection for negative partners was so great. So in 2011, they stated that there was a 96% reduction in linked transmissions in the immediate early ART arm compared to the delayed ART arm. Next slide. And they continued this, back one, sorry. Sorry. So what they saw, and they continued the study till 2011, was at the very end of the study, they got a 93% lower risk of linked partner infection than people who were in the delayed ART arm. So you might think that's fantastic, a 93% reduction in transmission. That's a hugely positive preventive tool, but it's not quite U equals U, and that's what people sometimes misunderstand about the 052 study. Next slide, please. And if you can do one more click, thank you. So this is a bit of a complex slide, but I wanted to just look in a bit more detail at the 8 negative partners who became HIV positive when the positive partner was on treatment. So the cases are listed A to H, and if you look in the red box, what you can see on the left of the red box is the number of days between the partner starting antiviral therapy and the negative partner becoming HIV positive. So what you can see is that sometimes the partner became positive even before the positive partner went on ART. It was between -5 days and +4 days. So they were in the first week of the positive partner being an antiviral therapy. And if you look at the far right of that red box, you can see the viral load of the positive partner, and it was not suppressed. So these transmissions happened before the positive partner was suppressed. If you just click on. So if we then look at the lower 4 cases, you can see that these happened many years later after the positive partner had been in treatment. But you can also see, looking at the right of the box, that the partners were failing treatment, and this really reinforces how important it is for U equals U to give people the support they need to stay on treatment and to stay fully suppressed. So in these later 4 cases, positive partners were again not suppressed when the negative partner became positive. Next slide, please. So if we look at these 8 cases in summary, what you can see is the first 4 cases, the positive partner had been on antiviral therapy for less than a week, so the viral load was not suppressed. And then the later 4 cases, the positive partner was unfortunately failing therapy and the viral load was not suppressed. So there was a 100% reduction in transmission if the viral load of the positive partner was less than 200 copies. So U very much equals U in the 052 study. Next slide, please. So you might think that's a randomized controlled trial, that's the highest level of evidence, what more do we need? Surely U equals U. But we thought you probably needed a bit more evidence. U equals U at the time was such a transformative statement, such a landmark statement, that we really wanted the most robust evidence possible to underpin the statement. So we set up the partner studies, and we did that because although we had good evidence from heterosexual couples about the reduced risk of transmission from condomless sex with suppressive ART, very few of the studies had included gay men. So in HBTN 052, only 2% of couples were gay couples. So along with the other studies, there was no direct evidence for anal as opposed to vaginal sex. And we also know that condom use effectively prevents HIV transmission. And in all the transmission studies, couples used condoms. They used them intermittently, but they used condoms. And we really wanted to see what was the preventive role of antiviral therapy on its own without using condoms. And also because in the transmission studies, just because you found no transmissions didn't mean that this was zero. You wanted to get really large studies to be very sure of your estimates of zero. So that's really why we set up the partner study. Next slide, please. So the partner study was what we call an observational study, and it was in 72 centres in Europe, and it was in 2 phases. So the first phase followed gay couples and heterosexual couples, and the second phase followed gay couples only. And the aim of the partner study was to estimate the risk of within-couple transmission of HIV during periods when condoms were not used and the positive partner was on suppressive ART. Next slide, please. And I just would like to give grateful thanks to all the people who participated in our studies to help us answer this really important question, who gave up their time and put their energy into the study, and we are hugely grateful. Next slide, please. So I'm going to spend just, sorry, if you could click on and click on. That's great, thank you. So I'm just going to spend a little bit of time talking about the methodology for the study, because I think when we talk about U equals U, we have to understand how robust these studies were and how much thought we put into the methodology of the study, so we were really sure that the results that we got were very accurate. So we only included a couple of years of follow-up in the partner studies between HIV tests in the negative partners and viral load in the positive partner if the couples had sex without condoms during that time period. If the negative partner didn't use PEP or PrEP, although we encouraged them to, if they chose not to use it, we included that time period. And we only included it if the viral load of the positive partner was less than 200 copies. And then we reported, as I said, the rate of phylogenetically linked transmissions during eligible follow-up. So if a negative partner became HIV positive, then we obtained HIV1 Pol and N sequences from either plasma or PBMCs, and we did this by Sanger sequencing, complemented by Illumina deep sequencing in a subset. And then we got control sequences so that we could construct our phylogenetic trees. Sorry, if you click on. And again. This enabled us to construct, as you can see on the right of the slide, what we call the phylogenetic tree. And so we got the control sequences, or the 10 closest sequences through blast searches of GeneBank, replicate partner sequences in red, or known transmission pairs in orange. And a seroconversion event, if a negative partner became positive in the partner study, we classed that as a linked transmission if the partner sequences clustered together on a monophyletic branch with high statistical support. And we defined that as a bootstrap value of greater than 0.9 or a posterior probability greater than 0.95, and they had a pairwise genetic distance of less than 0.15 nucleotide substitutions per Pol site. So I know that might seem a bit complex and a bit more detail for people, but it was really to show you how robust the methodology was to underpin the results of our study. So next slide, please. So this is where we got to at the end of partner 1. We'd got 1,238 couple years of follow-up, a third from gay couples. And during that time, couples had sex without condoms 58,000 times, which is a huge amount. And we got 0 phylogenetically linked transmissions to the positive partner. But if we looked at our estimates of 0, and what you can see with the dotted line is for every study that you do, you want to think about how precise your estimate is. And the way you do that is by looking at your confidence around the estimate. So the bottom bar in heterosexual couples in dark blue, the absolute worst case scenario, sorry if you click on, was the upper limit was 1 transmission after 217 years of condomless sex. But because we had less follow-up in gay men, if you click on again, the confidence around this was less. We just didn't have a large enough study by this point to be really sure of the result in gay men. So even though the absolute worst case scenario was you'd have to have condomless sex for 120 years to get the outside possibility of 1 transmission, we didn't see why gay men should have a lower level of evidence than people of heterosexual sex. So we kept going with the study. Next slide, please. And if you click on, and click on again, thanks. So we were quite glad that we did, because when we published the result in JAMA in 2016, it was accompanied by quite a negative, or not a negative, a conservative editorial. And they essentially said, how safe is this? That was the subheading of their editorial. Clinicians need to be clear that even though the risk is small, the risk is not 0, and the actual number is not known, especially for higher risk groups such as gay men. So although we thought that the evidence by this point was really clear, it obviously was going to take a greater degree to convince everyone, so we kept going. Next slide, please. But meanwhile, the evidence just kept coming. So this is the Opposites Attract study, which was a really nice study from the Kirby Institute in Australia, which was done by Andrew Grulich and Ben Babington. And it was quite a small study, but they got about 12,000 condomless sex acts in gay men when they didn't use PrEP, and again, 0 linked transmissions. So the evidence just kept coming. Next slide, please. Thanks. And then what we hoped was really the final word in this, the final piece of the jigsaw. So I presented in AIDS 2018 the final results of the Partner 2 study. Next slide, please. So this was a real-world study. So by the time we got to the end of partner 2, we'd almost 1,600 eligible couple years of follow-up just in gay men. And the couples had had sex without condoms 77,000 times during the study, which is a huge amount. And this is a real-life study. You can click on. So 23% of the negative partners were diagnosed with STIs during study follow-up. Click on things. A third had sex with other partners outside the main partnership. And click on. And as I said, almost 77 times the couples had sex without condoms. If you can click on things. And so what we got from the study was that 15 of the initially negative men became HIV positive during the study, but they did not get their infection from their positive partner on antiviral therapy. We had 0 linked transmission. So after 77,000 condomless sex acts, none of the negative partners got HIV from their positive partner on suppressive ART, very much proving, I think, once and for all that U equals U. Next slide, please. So I just want to spend a little bit just talking through the phylogenetic tree so that really everyone understands how robust this is. So of the 15 HIV positive partners, 6 of their seroconverting negative partners had acquired non-B infections, so that obviously did not come from their positive partner. And if you look at the tree on the right, what you can see is the partner controls and transmission controls in red and orange always clustered together with high supports on the same monophyletic branch. But in contrast, the partner sequences in blue do not cluster together. They're very widely separated on the phylogenetic tree. And the median pairwise genetic distance was 0.068, with a genetic distance always greater than 0.04, so they were not linked transmissions. So we're very, very sure that the negative partners did not get their infections from the positive partner on treatment. Next slide, please. So if you remember where we were at the end of partner 1 for gay men, it would take 120 years of condomless sex, obviously outside somebody's lifespan, but we thought we were just going to get evidence such that no one could ever query it. Next click, please. So this is where we were, and if you click on, thank you, at the end of partner 2. So around the estimates of 0 transmission, you would have to, as an absolute worst case scenario, have sex without condoms for 435 years to even have a mathematical possibility of a transmission. So very much U equals U. We think that's it. Next slide, please. So despite all the concerns about potential risks, if we look at the evidence for U equals U, there hasn't been a single verified case in the literature of HIV transmission in the context of completely virally suppressive ART. And by contrast, if you look in the blue bubble, all these large studies, really large studies designed specifically to look for cases of transmission when the positive part was suppressed, and we were absolutely unable to do so. If you click on. So there's 0 evidence that HIV transmission is actually possible with a suppressed viral load. So the science is there, the data is indisputable, the virus simply cannot be passed on if you're on suppressive treatment. Next slide, please. So I think people, because this is quite a new concept, even though the evidence is incredibly robust, people always say to me when I give these talks, yes, but. And some of that was summarized by Trip Gulick. He gave a sort of pro and con session in ID Week in 2018 with the kind of questions that people raise. So I'm just going to go through a few of them, the yes, buts. Next slide, please. Next slide, sorry. Thank you. So the big yes, but that I get asked is, yes, but what about genital shedding? So we know that the HIV viral load in semen is strongly correlated with your blood HIV viral load. And we know that men who are on suppressive antiretroviral treatment will intermittently shed HIV RNA, and about 6 to 8% of men will do this, but most of it is at really low level. It's less than 2,500 copies. Next slide, please. And this really nice study from 1995, if you look at the figure on the right, what this looked at was it looked at HIV RNA in seminal plasma, and they actually tried to see if they could culture it. Was this a viable vaccine? So, viable virus, sorry. So if you look at the kind of log levels you were getting between 2 to 3, you're simply unable to culture the virus. You would have to get very high levels in semen before you're able to culture the virus. So what this shows is that low-level HIV RNA in semen that you get in people who are suppressed does not translate into a risk of transmission. And this is because the HIV in semen is either defective, it's not replication competent, or it's just not reaching a concentration required for transmission. And you also see this with the 2 drug regimes, so dolutegravir and 3TC. And we know that the participants in all the transmission studies would have had intermittent shedding. We know it would have happened in partner, even though we didn't look for it. And there were 0 transmissions. So genital shedding, we know it happens. It does not impact on U equals U. It does not impact on the risk of transmission. And I think that's very clear. Next slide, please. So the next question I get asked is, yes, but you're only as good as your last viral load. So we know that U equals U is only easy to apply when people living with HIV have access to testing, effective treatment, viral load monitoring, and support to reach and maintain viral suppression. But in these circumstances, the risk of viral load rebound is incredibly low. So essentially, previous viral load measurements predict future. And this is some UK data, and the rate of rebound was 1% per year in people who had been fully suppressed for a number of years, and most of the rebounds were temporary. So if you are adherent to treatment, you will not rebound to any extent, and it will be the reason that we chose is so that people could have these intermittent blips that you see and still not have any risk of transmission. So to people who say you're only as good as your last viral load, I would very much say you are as good as your last viral load. If you were suppressed previously and you're adherent, you will be suppressed in the future. If you click on, please. And so partner was real life. We only measured viral loads in partner in many people annually. We didn't measure them every month or every 3 months. And people were adherent, and there were very, very low numbers of couple years of follow-up where people blipped above 50. So it was a real life study. So yes, you are very much as good as your last viral load, and that's not a reason to not believe or to discount U equals U. Next slide, please. So the other question I get asked a lot is, does U equals U apply in the first 6 months in antiviral therapy once you're suppressed in blood? What is this magic number of 6 months? And to me, the real question in early antiviral therapy is, does genital suppression lag behind blood viral load suppression? So this is a really nice study from 2017. And what you can see is they looked at suppression of viral load in blood in the top part of the figure compared to semen in the lower part of the figure. And they looked at 3 different backbones, so elvategravir, rilpivirine, and darunavir. And what you can see is that in blood and semen, you have the same 2-phase dynamics. So you have the initial rapid phase and then the slower second phase out to the end of the figure, which is 12 weeks after starting therapy. So what you can see with elvategravir's rilpivirine is it very much mirrors in semen the reduction in blood. So by the time actually ahead with rilpivirine is you're actually ahead, you suppress in semen before in blood. But even with dolutegravir that lags slightly behind in semen, by the time you get to 12 weeks and you're suppressed in blood, you're suppressed in semen. So that's really the question. Once you are fully suppressed in blood, you're likely to be suppressed in genital secretions. And I normally say below 50, then U equals U applies. You don't need this magical 6-month figure. Next slide, please. So I hope over the last 20 minutes or so, I've really convinced you about just how robust the science is. The data is indisputable. The virus just can't be passed on, and we need to keep talking about it. And I think the big issue, and the thing that Bruce is so wonderful about, and the U equals U campaign, is actually to disseminate this message. So scientists were not that good at getting the message out. So we know U equals U transforms the social, sexual, reproductive lives of people living with HIV, dismantles HIV stigma, which is such a negative impact on the mental health of people living with HIV, encourages testing, treatment, staying in care, staying on treatment, and it gives a very strong argument for eliminating universal access to care. But I think, as I said, we're not very good as scientists and clinicians of getting the message out. And there's a lot of evidence now that people living with HIV, their partners, policymakers are just not aware of how successful treatment is in preventing transmission. And if you click on, thanks. And I think that the robustness of the data is really underpinned by CDC. So mid last year, they actually gave an effective estimate in both heterosexual couples and gay men for antiretroviral therapy of 100%. So what they're saying is if you take treatment and you're suppressed, there is a 100% reduction of sexual transmission of HIV. I mean, this is just incredible because it's so hard for science to prove a negative, but we are so comfortable with this that CDC were happy to say it's 100%. And if you click on, and Anthony Fauci, who's ongoing hero of the hour with COVID, he has been very supportive of U equals U. He regards it as the foundation of ending the epidemic, which is an incredibly important statement for someone like him to say, who's such a leader and a role model in the field. If you can, next slide, please. And click on, thanks. So when we published Partner 2 in the Lancet late last year, we worked with Bruce Richmond and Prevention Access to try and publicise, to try and use the science and to generate publicity about it. And for a couple of days, it saturated the airways, and we hope in some small way we got the message out. But I think we need to keep talking about it. So next slide, please. So thank you very much for listening to my talk. I hope I've managed to convince you, if there was any doubts left in any of you, that science is there, it's indisputable, and people in effective treatment simply cannot pass on the virus. Thank you very much.
Thank you so much.
Okay. Sorry, I got a call in between. I got a call in the middle from my daughter. I hope it didn't mess it too much.
No, it didn't. It was fine. It was very good. It was very good.
Thank you, Dr. Alison Roger. That was Dr. Alison Roger, one of the principal investigators of the Partners 2 study. We are now moving forward with our agenda. Our next speaker for this session is Bruce Richmond. Bruce is the founding executive director of Prevention Access Campaign, which launched the Undetectable is equals to Untransmittable, or U equals U, which is a global community-driven movement with over 990 official partners in 100 countries, sharing the revolutionary but largely unknown fact that people living with HIV on treatment with undetectable viral load cannot transmit HIV to sexual partners. In 2012, 9 years after his diagnosis, Bruce learned U equals U, and after recognizing that people with HIV and public were not being informed about this groundbreaking science, he joined with activists and researchers to create a consensus on the science and to ensure it reaches the people it was intended to benefit. So for this morning, Bruce will share some of his experiences in the U equals U global and regional movement, which are community-led and also being endorsed by some of the community organizations all over the world. Bruce, over to you.
People use such a priority at this conference, outside this conference. There's a little bit of a sound feedback. Can you hear that? Is that okay?
It's okay.
Okay, great. I want to shout out, this is actually a special presentation because my family is watching from Massachusetts in the United States. I'm really excited to share with you the message of U equals U, why U equals U is so important, and talk about the movement that got that message out to the public and how you can help be a part of this movement and share the message with the people who've intended to benefit from it. First, I want to address my privilege. I am very privileged, white, cisgender male from New York with health insurance and food stability and housing. And that's enabled me to get to and maintain an undetectable viral load. And there are so many people in many parts of the world who do not have an undetectable viral load by otherwise circumstances out of their control. And so we need to make sure that U equals U reaches everyone. And during this presentation, I'm going to talk to you about one way that we can do that. So what is undetectable is untransmittable? I think most people know this. It means that a person living with HIV who is on treatment and has an undetectable viral load, and for the purposes of untransmittability, diet. So many of us, like myself, who are living with HIV, never imagined a time when we could love, we could have sex, or we could conceive children without fear. Fear had been present in the most intimate moments of our lives. And U equals U sets us free. It changes our social lives, our sexual lives, our reproductive lives. And it dismantles the stigma that we have been living with and dying from for decades. And the stigma that we know is one of the greatest challenges to impeding, challenges to ending the epidemic. Also, this was very new for me when I came into the field. I didn't know a lot about 90-90-90 or treatment goals and care continuums, but U equals U is really important for our treatment goals because it reduces the anxiety associated with testing for HIV, so people are more likely to get tested. And if diagnosed, this is another encouragement to start treatment and stay on treatment and in care for our health and to prevent transmitting to those we love or want to have sex with or want to conceive children with. And this is really important, and I'm going to spend a whole slide on that in a minute. But U equals U is a public health argument for getting people all services and care and treatment which will get us closer to ending the epidemic. So let's look at that again a little bit more now. This is called the U equals U public health strategy. So I think all of us on this webinar are really committed to ensuring or other kinds of decision makers, we're saying that we need access and reduce barriers to treatment, care, and diagnostics to improve our lives, for the well-being of people living with HIV. Now that should be enough. But for some people, influencers and policymakers, they're not really concerned about our lives. That's not really influential in their decision making so much. What they are concerned about, though, is preventing new transmissions. So, because that will get us closer to ending the epidemic. So when we talk about increasing access and removing barriers, whether it's treatment or viral load testing or housing or mental health counseling, we talk about that. We've got to connect it to preventing new transmissions. That's for our health and to prevent new transmissions, because we have to say if we want to end the epidemic, we're going to need to invest in the well-being of people living with HIV. I also want to return to that concept that U equals U is important for treatment goals. So there was a very, very large study, one of the largest studies of patient-reported outcomes called Positive Perspective Ways to. And what it found is that when people living with patients living with HIV were informed by their healthcare providers about U equals U, they were more likely to report treatment satisfaction, optimal adherence, and viral suppression. So that's really important. The people who heard about U equals U from their provider were 2 times more likely to report viral suppression. But we also found in that study was that 1 in 3 people living with HIV were not aware of U equals U. And that's something that we have to do something about. And this is emblematic of why we need the U equals U campaign. So first, not all people with HIV were being informed about U equals U. But folks like myself, really well connected in the medical establishment, incredibly privileged guy, I learned in 2013. But what I started noticing, and my colleagues started noticing, that it was really marginalized folks who were not well connected to care, not being, their needs were not being met by the healthcare system, or were being left out. And that's not fair. We believe that all people living with HIV have a right to accurate information about our bodies. It's really, really that simple. And finally, we know HIV stigma is an emergency. It is a public health crisis, and we need to respond to it that way. Hundreds of thousands of people in my country, in the United States, and millions around the world are suffering because they and other people think they're infectious, and they're not. And we also know that U equals U is good for personal health or health outcomes, and also for public health. So it was really this urgency to get this message out. But what we found is, the U equals U science that Allison spoke about earlier didn't really have a publicist. Back in 2016, when we started the U equals U campaign, the studies were promoted independently very well by the institutions that funding. So you have streams of media releases for each different study. But in terms of the aggregate of all that science, the aggregate of the studies that prove U equals U, there wasn't anybody taking care of that, with the exception of the Swiss data in 2008. So our concept is tell the truth, or we are going to tell it for you. And so that's what we did. Back in 2016, we approached the principal investigators from the studies that Allison mentioned and the author of the Swiss statement, which was the first statement to come out and say U equals U. It was the Swiss statement and widely discredited, as Allison mentioned. And we said to them, your science isn't getting out to the public that it was intended to benefit. And so we worked on a consensus statement with them to confirm U equals U was true. And then we created a video with people living with HIV demanding that all of us be told. And so our idea was to take that statement, the video, and our voices and go out and change the narrative about our lives. So the strategy was to engage influential people and institutions to join us in confirming what we knew was true. We launched in July 2016, and very quickly, New York City signed on. The Department of Health and Terror Savings Trust was already working on their campaign. So it was a really exciting time when we launched. And at that time, we also started our conversations with the U.S. Federal Health Departments, with the CDC and NIH and HHS, to urge them to change their assessment of the risk from our bodies. And something beautiful happened, really because of social media and some of the international organizations that joined us. This just took off all over the world. And I'm going to show you some campaigns later. But many of these protests and demonstrations and press conferences, and they were really celebratory. This was great for leaders to share, and we really wanted to inspire people to join us in sharing the news. Now, because of the activists, the researchers, the public health officials, pharmaceutical companies, the journalists, all these people coming together, we now have 1,010 community partners from 102 countries. That's more than half the countries in the whole world that have signed on and committed to getting this message out. But at the highest levels, the CDC, PEPFAR, UNAIDS, USAID are all saying U equals U and supporting this message. Dr. Fauci, it's great to have friends in high places, arguably the most renowned immunologist in the world. The science does verify and validate U equals U. In 2017, he said quotes every year that were absolute gems. The next year, he said, from a practical standpoint, the risk is 0. And then he said the following year, just a year ago, that it's impossible for a person to transmit, and that U equals U is the foundation of being able to end the epidemic. So how are we doing? Well, we're not doing that well yet. There's still a lot of resistance, and the United States is one of the most difficult places to get people to actually take action. So what this recent study showed from 2019 is that that only up to 18% of people in the southern United States believe that U equals U is true. And then in this study, this was pretty disturbing actually to me, that 38% of people who agreed that U equals U was completely accurate. So only 38% of them agreed that U equals U was there. So that's not a lot of people. And then only 31% and 39% believe that the transmission risk was actually 0. So when people said that it was completely accurate, they didn't know that that actually meant 0 risk. So there's a lot of different theories about this. And then in another study that we did with Merck, only 31% of HIV positive respondents reported that U equals U accurately, and this is really bad. 28% of negative millennials said they have avoided hugging, talking to, or even socializing with someone who's HIV positive. So that was pretty bad. This was some studies in the US. But fortunately, there's a lot of momentum around the world, and I'm going to show you some of it. And England's really the epicenter of U equals U because of all the organizations on the bottom, the leading national organizations that have all created their own campaigns and have all been really passionate about getting this message out, starting with Terror Savings Trust in 2016. Vietnam has the best national program. It's really exciting. They launched the K=K program, supported by the US CDC, by PEPFAR, and the Vietnamese government. It's just a brilliant, comprehensive program, and I know Asia from the CDC will be speaking about that later in this conference. And this was the first national campaign, a 7-city campaign in France in December 2016. These are some outdoor campaigns in the United States. Washington, D.C. on the top, on the bottom is Arizona. On the top, on the right, it was on billboards and buses in New York City. Excellent campaign in China, yet led by young people from Beijing, Love Without Borders. They just had a youth conference, and this really cool campaign on Instagram from Indonesia, a homegrown campaign. On the left is from Ireland. On the right is the first national campaign in Italy. On the left is our nurses who went out in the freezing cold snow in Kazakhstan to make an age. And on the right, these are teenagers, the Teener Graduate Program in Russia, making age campaigns. Lots of activity in Latin America. The Brazilian health ministry signed on and updated their U=U or IEC guidelines in 2019. Lots of different activities. ONUCIDA and CAS actually launched a campaign as early as December 2016, an I=I campaign as part of their testing outreach. This is really important to me because on the left, this is a campaign for the oldest indigenous tribe in Venezuela. And this is, Venezuelans are people with HIV in Venezuela especially are facing the greatest humanitarian crisis since the beginning of the epidemic. And they started having a campaign to inspire hope and to advocate for treatment access. And on the right is the first Arab campaign in Lebanon. And I'm really excited to bring some social marketing campaigns and excellent. And I met this group and I was just fangirling and so excited. Just absolutely love that. I was so excited to meet them. And I actually sang with one of the band members. No one will ever see that. And then this is National Campaign in Zambia, which is also really impressive. That's the president of Zambia on the top left, signing on to the campaign with Community 2 activists. This is also funded by the CDC and PEPFAR and the health industry. So much creativity. That was the rock star of Zambia. And then we're seeing celebrities starting to talk about U=U. The guy on the right with the long hair is Jonathan Van Ness from Queer Eye for the Straight Guy. He's actually reached places in Southeast Asia, in Japan. On the bottom was a U.S. presidential candidate. On the top left is Prince Harry, and on the bottom left is Garrett Thomas, who is an international drug star. So, how do you talk about U=U? Like, what are some of the basics for U=U? When people say that U=U is too complicated or there are too many nuances to talk about it, it's because they're uncomfortable talking about it. Don't let them get away with that. It's not that complicated. It may be complicated to you because people may be experiencing challenges like treatment access or housing stability and all sorts of things that make it difficult, but the basics are really not that difficult. Take your treatment as prescribed. Take your medication every day. Get your labs done regularly and stay connected to care. TLC, in the US, we also talk about that meaning tender loving care. Give yourself some TLC. It's really not that complicated either. It's under 200 copies per milliliter. The number to know is 200. This is about sex. This isn't about breastfeeding or injection drug use. These studies are focused on sexual transmission, and this prevents HIV. It doesn't prevent other STIs, so you might want to consider condoms for other STIs. So communicating U equals U. Let's just stop for a second. So we're actually talking about the risk between one human being and another human being in the most intimate moments of our lives. And the words that we choose to use, can either bring people together to experience love and intimacy that they never thought would be possible, or it can tear them apart and cause great harm, really, really tremendous harm. So when we talk about U equals U with the four C's, we have to be clear, we have to be confident, we have to be consistent, and we have to be conscious. So we'll go deeper into these. So clear, we really can say these things on the left now. We can say all of these things on the left. Zero risk, impossible. But if we say these things on the right, all of these open up a little window of risk, even virtually impossible. People think that means that it's still possible, or extremely, we've got to be clear, because when you open up a little window of risk, we put our lives at risk. It's like saying, oh, someone's a grenade. Well, they're a little grenade. You're still a grenade. No, gotta be clear, gotta be clear. And we hear from medical professionals a lot that you can never say zero. They'll say you can never say zero. Well, you can say zero. As we showed earlier, Dr. Fauci says zero and impossible. Dr. Alison Roger, who you saw earlier, zero. Very clearly listed zero. The British HIV Association is actually encouraging doctors and their members to say no risk or zero risk. They're encouraging to put that out. And finally, as Alison said earlier, the Center for Disease Control has said it's 100% effective at preventing sexual transmission. Now, that's as effective as not having sex at all. That's pretty effective. And confident. These are the buts also that Alison had talked about. Don't say, I believe in U equals U, but use a condom just in case. That kind of erases everything before the but. But what you can say is condoms and PrEP are not used to consider condoms and PrEP. I mean, for instance, condoms can help prevent other STDs and pregnancies. And if you don't know if your partner is struggling with adherence, then condoms and/or PrEP could be a good idea. And if the partner is having sex with other people, like my undetectable status is not going to protect my HIV negative partner if he is having sex with other people. That should be obvious, but it's not always. And there's no shame about being HIV negative and wanting to use PrEP or condoms with the HIV positive undetectable partner for that added sense of security. It's not necessary, but it may be emotionally important for someone. Also, again, as Alison said, you're only as good as your last viral test. Don't say that. Don't say that. That means at any moment I could be infectious, and that's very unkind to say that. Be encouraging. You take your medications as prescribed, have your regular viral test, and you don't need to worry. The other one is just a catch-all. I believe in U equals U, but you never know. Well, we do know. And then consistent. Okay, we've got to think about this. So change about anything is really uncomfortable. People don't like change. Most people don't like change. Some people thrive on it, but there's a lot of research that shows people are uncomfortable with change. And they're stuck in old ways of thinking. And so when new ways of thinking come along, it's uncomfortable in the middle. So they do whatever possible to reduce that discomfort in the middle. That's called cognitive dissonance. You're in between these two. And so we're fighting against that cognitive dissonance in the field. A lot. People will even look at data that's incorrect to confirm their pre-existing ideas. There's lots of research on this. And so what we need to do to kind of break through that cognitive dissonance is to make sure that people are hearing this repeatedly and from the right people and from credible people, credible sources. So we see a lot like UNAIDS is continually getting this message out on social media over and over again. It's really important. And Matthew Hodson, CEO of AIDS Walk Map, is doing the same thing. Try to continue to get this out on whether it's social media, all of outreach activities, will do information on the walls throughout your offices. There's newsletters, treatment guidelines need to be updated. There's lots of ways to get this out in a consistent way. Make sure that it's part of your speeches for World AIDS Day. I'm telling you right now, if I see and hear another speech on World AIDS Day that says we have the tools to end the epidemic and all the other stuff that's important and true that we've been hearing forever, and then they talk about stigma, they don't talk about U equals U, I'm not sure how I'm going to control myself, because we saw it last year, all these speeches about how bad stigma is, and then they're not talking about the most important tool we've ever had to reduce stigma. So it's speeches for AIDS, World AIDS Day. The barriers that make it difficult or impossible for them to get to undetectable, especially communities that are left out, Black and brown communities, sex workers, people who inject drugs, and it's really, really important, transgender women. It's really, we've got to really focus on acknowledging those barriers and also saying none of us are a danger, regardless of viral load. If someone has a detectable viral load, there's still, condoms, and in some parts of the world there's PrEP for hot, safer sex. And also the other thing is, sometimes we see these campaigns that are like seek to get to undetectable so we can end the epidemic. That it's our job, it's our role. Well, no, it's actually our personal health decision. It's not our responsibility to be prevention tools. This is about us. This is about our lives. And we do have an opportunity to participate in ending the epidemic, but let's make it about the human being rather than focusing on them as a prevention tool. And then finally, as I was mentioning about those barriers earlier, and talking about my privilege earlier, is that we've got to use the U equals U public health argument. In our advocacy for increasing access and removing barriers, whatever those barriers may be, so that all people living with HIV can stay healthy and get to a place where they have hope for their lives, for their relationships, for love, for children, and they won't prevent, and then they'll prevent from transmitting HIV. They won't pass it on. That's so important. We have to make sure that the hashtag leave no one behind is more than a hashtag in this field. So I'm ending a little bit early, but I'm pleased to end with my friend Allison Roger. This is a moment, one of the best moments of the U equals U campaign, and one of the best movements, if not the best moment of my career, when we had this conversation at the World AIDS Conference in Amsterdam in 2018.
providers that are still not accepting this message. They try to focus on the risk is not zero scientifically, or they focus on the patients are going to be appearing there's technical or standards of outcomes already, so they're going to be sure to the patients. We get every single kind of excuse. What would you say to clinicians or any other clinicians, providers, that hold this information for people?
I just want to contribute to the equals you in astonishing. I think the time for excuses are over. I think it's very, very clear that the risk is zero. So I very much think that the significant zero on successive aerosol infection and infection.
I still get teary-eyed every time I see that. That was a really, really important moment. We have used Allison's quote in that video all over the world. The time for excuses is over, and it's very clear the risk is zero. So thank you so much for being here. If you want to get involved, here's some ways. You're joining the campaign. If you're part of an organization, you can sign on as a community partner, join and be a part of all of our newsletters and resources to share. Learn the facts. Really important to know with a little bit of feedback. To learn the facts, all kinds of information on our website, preventionaccess.org or youth.org. Share the great news. I hope that everybody on the webinar has the opportunity to tell someone living with HIV, U equals U for the first time. It's really transformative. And I'm so lucky I get to do that a lot. And you'll see how much it changed their lives. The look in someone's eyes when they realize that they can be intimate without being afraid, finally. And leave no time. Again, I can't stress enough that we've got that public health argument to make sure that everyone living with HIV has the option to get a protectable experience, what it means to be undetectable and untransmittable. Thank you so much. I'm so happy about this conference. I really appreciate this opportunity to be here, and I'm just glad all of you are part of changing what it means to live and love with HIV around the world. Thank you.
Thank you, Bruce, for that inspiring presentation, inspiring talk. And as Dr. Allison has mentioned, the time for excuses is over, and I borrowed her words. No time for excuses. U equals U in Asia and the Pacific. Am I in? Am I live?
I can see you.
Okay. Thank you, Bruce. We're live, right? So thank you very much, Bruce, for your time. I know that it's already 10 o'clock in the evening there in New York. And we are very much happy here in APCOM for you to be part of the RRRAP conference. Dr. Nitia, hello. And I'm happy that you're here. Regards to you, Bruce. Great talks by Dr. Roger and Bruce. And Dr. Nitia actually has a question. She asked that, should we be concerned about durable undetectability? In Thailand, the first viral load is allowed. Can we say U equals U after the first undetectable viral load at month 6? Otherwise, we'll need to wait for another year. This is our practice, but doesn't seem to be supported by guidance or guidelines.
Oh, I think that, So NIH will say, can you hear me okay?
Yeah, yeah.
Okay. So NIH will say that after 6 months of an undetectable viral load, then someone can count on their undetectable viral load for HIV prevention. And then there are other places that say after two consecutive viral load tests to make sure that it's durable. Now, I think the question was that you're only able to get viral load tests once a year, the first one. Is that right, Matt?
Yeah. I think so I think
In terms of the
go ahead, Bruce.
I was just going to say that, from what I've heard from our researchers, it's durable, that once someone's undetectable, they're undetectable, as long as they take the medication as prescribed. So I wouldn't worry about, going a year, after 6 months, if someone's undetectable at 6 months, then, according to sort of what NIH is saying, then you're okay. There isn't guidance in terms of how many viral load tests you need to get in that 6-month period. Does that make sense?
Yes. So so tomorrow we will have more discussions on the science of U equals U. We are inviting Australian Society of HIV Medicine to talk about the U equals U guidance that they had just launched last week during the ASHM joint HIV and sexual reproductive health conference, virtual conference. And we are very much happy that they will be joining us tomorrow. And I think these questions we will be happy that if they can address this question according to their guidance, as what is mentioned from their conference last week. Dr. Nite, we will take note of that question for tomorrow. And there's another question here. So in the countries across Asia and the Pacific, there are the various levels of understanding or awareness about U equals U. There are countries where they are not aware about U equals U, and there are countries where, for example, Thailand, we are already moving forward with U equals U in delivery of health services. In Philippines, it's already being made part of the health strategy of the Department of Health. So for countries where U equals U is not being really advocated for, what is your advice to the community on where to start?
Yeah, well, I think what we work with partners is really starting about building a coalition, building your base. You can actually go to our website and look on the community map, and you can see if there are other organizations that have signed on in your country or your region, and get together with them, really start building your coalition, and then finding your champions in different sectors. In a community sector, see if you can find someone in the health ministry that's a champion, potentially funders, clinicians, and sort of building, sort of an advocacy, building your base, and find your target. And your target is probably the health ministry. That's kind of what our goal is. The country is to get the health ministry on board. And so you show them what's happening. The WHO is supporting this. UNAIDS is supporting this, and this is what's happening in this country and another country, and you present that this case for you've got science, top institutions in the world, the top researchers. You've got examples of other countries that are doing this. You don't want to lag behind in your country, and that is often been successful. But if there's anyone specific that wants to talk about it, you can please email me, and we can see if you're in one of the countries that we're sort of expanding the program and helping advocates on the ground. So please send me an email, and we can explore that. But it can be done.
Yeah.
It only takes a few people that start working.
Yeah. Thanks, Bruce. And I think the most important point is that the people living with HIV also understands what U equals U is. So I think it's not really a secret, but I am also living with a person living with HIV with undetectable viral load for 7 years. And learning U equals U, it's kind of like empowers more of the advocacy that we are doing, and the understanding from the community of people living with HIV really much helps increase the support that we need for the community. And I think it's like this kinds of conversation with you, Bruce, is really, really inspiring and empowering, like looking at you. So thank you very much. So speaking of, so this is the last question that we have. So if our participants, virtual participants, have more questions, please do chat in your questions. But this is one of the advanced questions that I got. So speaking of the empowerment, how will the principle of U equals U address the stigma and discrimination, not only from the health service provider towards the PLHIV, but also from the PLHIVs, like the self-stigma of the PLHIVs themselves?
I think that's a really good question. I think that the HIV stigma, the internal stigma that we face is really well addressed by U equals U, because you know, so many of us, like myself, felt dirty, and we felt dangerous, we felt toxic and shame because of our infectiousness. And I was, someone like myself, I was afraid to be intimate with anybody because I didn't want to pass on HIV, so I withdrew. And I think that you were seeing that when people feel that they has really lifted people up, inspired people, and given people hope, and you know, and reduced that internal stigma. I think the external stigma is harder because you're trying to change other people out there and trying to change decades of fear of HIV and people living with HIV. But in terms of profoundly transformative.
Oh, thanks, Bruce. And I think we need to call for more, like encourage more people living with HIV to speak up and to go out. I mean, it's not easy, but we're here. What's like, that's why we're here for, to kind of like empower other people living with HIV. This conversation between two gay men living with HIV, undetectable, is very much important, and this needs to happen, and this needs to be normalized. And I thank you very much for your dedication and for the passion to really address the barriers of making sure that people living with HIV has access to ART, and making sure that they are retained under treatment and become undetectable. So again, I think we can wrap up now. Bruce, thank you very much for your time. Thank you very much for your patience, and we thank the participants who's joining us here in the conference room, and also joining us virtually. Thank you very much. The U equals U sessions will continue by today and also tomorrow. So today, Bruce will moderate. Oh, this afternoon, Bruce will moderate one session on U equals U, sharing experiences from other countries. So we have speakers from Vietnam, Taiwan, Japan. I can't remember the others, but we have speakers from different countries. And then we have online demand generation on ART, also happening this afternoon. Tomorrow, we will be joined by Asham. And also, UpCom will be presenting some of our community perspectives about U equals U. And then in the afternoon, we will be talking about what Bruce and Dr. Nitia was just talking and pushing forward, how do we get U equals U into the HIV programming, and how do we convince the national programmers to make sure that the messaging of U equals U is integrated within our national guidelines or national HIV strategies. So basically that's the map of the U equals U sessions that we're having. Thank you very much. Again, Bruce, thank you very much. I'm really honored, there's no words for the thanks for your support to AppCom and for the community, and you're staying late. So thank you so much. Okay.
Thank you. It was really an honor to be here, and I so appreciate AppCom commitment.
Yeah, and we will be seeing more of you. There's a lot to partnership between AppCom and PAC, and this is only the beginning. So thank you very much, guys. We will be back. We will be back at 2 p.m. For the U equals U session.